Okay, hello everyone, and welcome to today's webinar. I'm Mike Smith from KLAS Research, and I work closely with the AMA. As many of you may know, KLAS's mission is to improve the world's healthcare through insights, collaboration, and transparency. We do so by interviewing thousands of providers about their experience with various software products and services that they utilize in their organizations, and transparently sharing insights about these products and services through our performance database and reports. The expansion of the population in the US with chronic conditions represents a significant challenge for health systems and is a key driver for the shift towards value-based care. KLAS is actively monitoring many of the technologies used to manage the growing burden of chronic conditions, and that would include things such as telehealth technologies and services, remote patient monitoring, care management, value-based care, consulting and managed services, and population health. As more patients receive healthcare in their homes, RPM technologies are commonly being used to monitor their conditions. Hypertension followed by heart disease is the most frequently monitored conditions of patients using these technologies. We hope that our monitoring efforts of these different types of technologies, combined with some of the unique work that we're doing in the ARCH Collaborative to enhance clinicians' experiences with the EHR systems, are helping us fulfill our mission. The AMA's mission to promote the art and science of medicine and the betterment of public health closely aligns with KLAS's mission to improve the world's healthcare. KLAS and the AMA have been formally collaborating for the past several years. We're grateful to have had Dr. Michael Tuddy from the AMA on our physician burnout panel at last year's ARCH Collaborative Learning Summit. And at this year's summit, the AMA will be hosting a breakout session on their Joy in Medicine Health System Recognition Program, which is designed to help health systems reduce physician burnout and improve well-being so that physicians and the patients they support can flourish. We're excited about the work that the AMA is doing to reduce hypertension and grateful to have Dr. Michael Rakotz, Dr. Claudiana Maftari, and Shannon Haffey here to discuss the AMA MAP framework and quality improvement solutions for hypertension control. Just for some housekeeping, if you have any questions throughout the session, we're going to answer those or address those questions at the end. And you can post those questions in the Q&A that you see at the bottom of your screen. And I'd like to turn the time over to Dr. Rakotz. Dr. Rakotz.
All right, great. Thanks so much, Mike, and welcome everyone. Good morning or good afternoon, depending on where you are in the United States. This talk today, we're really happy to be here with a few of us from the Improving Health Outcomes team at the AMA to talk about mastering quality improvement, unlocking the power of the AMA MAP framework for hypertension control. Next slide. Just really briefly, I'm going to give you a brief overview of the AMA MAP framework. Then Claudiana is going to talk about and provide a little bit more detail into our quality improvement program for hypertension. And Shannon's gonna discuss briefly what it looks like to operationalize our framework and program at an organization like yours. And then we'll come back around to some a Q&A that will be done through the Q&A section of Zoom. Next slide. And you can go to the next slide. So like I said, I'm going to talk just for about 10 minutes, give you a brief overview of our work and how it sort of came to be and where we're headed. We are focused on reducing the burden of chronic disease in our Improving Health Outcomes team at AMA, and we focus specifically on reducing the burden of cardiovascular disease. Why? I think it's fairly obvious. It's the leading cause of death in the United States. Nearly 1 million people die every year due to cardiovascular disease. And just for perspective, I mean, that's a big number. I think it's hard to wrap your head around it sometimes. Where I went to school at the University of Michigan, the stadium holds 107,000 people. You'd have to fill it nearly 9 times to sort of quantify the number of people who die every year from cardiovascular disease. And I think what's really important here is that many, if not most of those cases, estimates sometimes as high as 80% of those cases are preventable. So if you go to the next slide, when we think about the contributing factors for hypertension and what can be done to try to mitigate those factors and reduce the burden of cardiovascular disease, focusing on blood pressure control or hypertension by by getting people from being uncontrolled to controlled hypertension, that alone would save more lives than any of the other contributing factors listed here. So while we focus on reducing the burden of cardiovascular disease, we try to get really tactical with improving blood pressure control first and foremost, because it has the largest impact on reducing death from heart attacks, strokes, and other cardiovascular diseases. Next slide. So when we started this work maybe 12 years ago now, and we took a look at hypertension, trying to figure out why sort of levels of blood pressure control in the United States leveled off. Since then, they've even been decreasing a little bit. We wanted to address we were brought in a panel of experts from around the country, reviewed all the literature, and really settled in on sort of three factors that drive control of blood pressure, or without them lead to uncontrolled blood pressure or uncontrolled hypertension. And they are inaccurate measurement of blood pressure, suboptimal treatment, and suboptimal adherence to treatment. And so when I talk about inaccurate blood pressure measurement, it's something that sounds like it's really easy to do, but it's fairly complex. Claudiana will talk a little bit more about that. But what we do know about measuring blood pressure accurately is that you need to have a standardized measurement protocol to do it effectively across a clinical enterprise. For treatment, we know that most people with hypertension will need 2 or more medications to get to goal. And sadly, in many cases, a majority of patients, or typically 40 to 50+% of patients, are on no medication or 1 medications, when again, they'll need 2 or 3 medications to get to goal. And this phenomenon of treatment inertia is extremely common. And as physicians, and I'm a primary care physician, we have a tendency to overestimate how aggressive we're being with these patients with hypertension. It's hard to explain why that is, but we try to put processes in place to try to mitigate that so that people receive evidence-based treatment in a timely fashion. And finally, the issue of adherence to treatment and follow-up, those are critical factors. Again, standardizing a few key clinical processes and having ways to track those can really help activate patients in self-management. And we'll go into that in just a little bit more detail in the next slide. So when we assess those 3 things being the major factors, we tried to come up with a couple of key strategies in our framework that would try to again mitigate those. So we created what we call the MAP framework. If you look on the right here, very simply: measure accurately, act rapidly, and partner with patients. That's the AMA MAP framework. It can be applied to any clinical condition, but as it relates to hypertension, measure accurately to obtain accurate and actionable blood pressures wherever they're measured, act rapidly to initiate and intensify evidence-based treatment when indicated, and partner with patients to support them in activation and self-management, assessing to improve adherence and follow-up. So this framework is really what we came up with originally, hoping to try to come up with a way to implement this in the form of a series of checklists or actionable tools that would make it easier for clinical teams to improve blood pressure control in a clinical environment. What we found, if you go to the next slide, was that we needed to have a little more of a structured program for this to work in the real world. So we took those same 3 strategies for measurement, acting, and partnering, and we built a little bit of structure around them. So we created supporting tools and resources to make it easier for clinical teams to do that. We provided peer-to-peer quality improvement coaching, which we call practice facilitation. So, physician to physician, nurse to nurse, pharmacist to pharmacist, et cetera, so that we have a team-based approach to this. And I think one of the big differentiators here for us is that we really recognize the importance of having performance metrics, dashboards, and monthly reports to make it easier for leadership within an organization, all the way down to the frontline teams, to have data to track these clinical care processes, not just the outcome. And the idea is that by tracking these performance metrics, we can drive better outcome, more blood pressure control in this case. Next slide. So in order to do that with those metrics, everybody, I think, probably on this webinar will understand the blood pressure control rate measure. The outcome metric used for hypertension is what percentage of patients who have a diagnosis of hypertension are treated to goal blood pressure at their last encounter. So most people track that. What we try to do in addition to that, if you look at the right to the little bubble that we have here, for each of those key strategies, we try to provide metrics that anchor to those key clinical care processes, so that if you're trying to use a standardized measurement protocol, what percentage of the time is that occurring? And we can provide that information to make it actionable for clinical teams to assess how well a site is doing, how well the system is doing overall, how well a department is doing in adhering to that blood pressure measurement protocol, which is so critical. Similarly, for acting rapidly, we've got a metric that looks, it's an intensification metric that looks at what percentage of the time that a patient's in front of you with hypertension that's uncontrolled, did the clinician take action to intensify treatment by prescribing a new medication or additional medication. And finally, with partner with patients, we look at a couple things. We want to see, we have a proxy for medication adherence that looks at what is the change in blood pressure on the visit after a medication intensification, which is, again, is just a proxy for medication adherence. And then finally, follow-up, which is, critical. Follow-up could mean a home blood pressure monitoring reported. It could mean a visit with a nurse or somebody on the care team. But together, these process metrics are really useful in tracking how well you're implementing these key clinical care processes that fall within this MAP framework. Next slide. And the program works. So this is our largest study. We implemented the program at 16 primary care practices in South Carolina. Baseline blood pressure control rates were 64%. At the end of 6 months after coaching and implementing the program and having access to dashboards and data, there was an absolute 10% increase in blood pressure control, at which time we backed off our clinical support, but left the dashboards and the monthly reporting. And 6 months after that, over 90% of the benefit was retained, which is extremely important because it's rare in hypertension quality improvement that 6 months after the intervention ends at 1 year, that you still see almost all of the benefit from the intervention. And so this has been, this is an important lesson for us to learn. Once we understood this, we started to roll the program out more widely across the country. Next slide. Now, to go into just a very brief overview of what our metrics look like in the form of the dashboards that we can provide or that can be built within an EHR system or Pop Health platform. You can go to the next slide. We try to keep them as simple as possible. So I told you that there are 5 key metrics that we track. This is just a visualization of those. The dashboard, can be accessed by whoever the organization gives permission to use it. It can be, chief medical officer, chief quality officer, other senior management, all the way down to a practice manager, physician, clinical team members who use it to track progress. These dashboards can be shown at the provider level, at the site level, at the department level, and at the system level. And you can see here those M, A, and P metrics are clearly shown on the right, tracking towards a goal that is defined by the organization so that you can track progress as you improve over time. A couple things to note about this is that there is a filter function available so that you can have demographic stratification of these metrics and the data, in addition to also being able to filter by comorbid condition like diabetes and high cholesterol. And patient level reports can be downloaded for providers so they can actually take action and identify lists of patients who may be uncontrolled, for example, and then get them to the appropriate, personnel in the office or care management team to bring these patients back in or address the gap that's been identified or the opportunity to improve that's been identified through this dashboard and these reports. Next slide. In addition to those metric reports, we also have, again, those are available at the provider level, at the site level, at the department level, and at the system level. We also have some customized reports that we can do for things like medication prescribing, really critical so that you can know what's being prescribed. Sometimes it's following an existing protocol that is in play at the organization, and sometimes you can find out where there might be some suboptimal prescribing happening with medications that aren't indicated. So very useful to see those patterns. And then we've got executive management reports, which allow comparison of providers, comparison of sites, comparison of departments to the whole system. So really useful, actionable reporting capabilities. Next slide. So with that, I want to turn it over to Claudiana, who's going to go into a little bit more detail. I know that was a very quick overview. We'll have time for questions at the end. So if you have them, you can either enter them into the Q&A or wait until the Q&A section of the talk, and we'll address them then. So turning it over to Claudiana.
Thank you, Mike. We can move forward to the next slide. We're going to spend the next 20 minutes or so just diving into some of the action steps that Mike mentioned in a few minutes ago. So again, our MEP framework, it's based on 3 pillars: measure accurately, act rapidly, and partner with patients. And these are all designed to overcome barriers that are causing uncontrolled blood pressure. So we're going to start with measure accurately. We can move to the next slide, please. Blood pressure measurement is error prone. And what we've listed in the slide here, there are 27 different errors that have shown to have statistical and clinical significance in the accuracy of the blood pressure. As you read through some of these possible errors, it's easy to see that some of these could be due to the device that we're using. Others are due to the preparation and positioning of the patients, and also the skills of the individual who's measuring blood pressure. So to overcome all of these barriers, we have identified specific action steps. Next slide, please. The first action step, it is using an accurate device. The second one is focusing on proper preparation and positioning technique. And the third step, it is creating a protocol and a workflow that supports repeat of the blood pressure measurement. When we talk about using the right accurate device, if we can move on to the next slide, you can see the first word is validation. This is an independent testing that happens before the blood pressure device comes to your institution or before it comes on the patient's hand. However, not all the devices that are available in the market are validated. So we have invested and continue to invest in developing and maintaining the validated bp.org website as a tool where you as a healthcare organization can go in to identify the validated blood pressure devices that you can purchase for your institution, or for any clinicians or care team member who is recommending a blood pressure monitor to their patient. This is a tool where, again, you can find validated blood pressure devices. The next step, it is calibration. Next slide, please. Calibration, it is the process that ensures that the device that you already have in your hand, it is working appropriately. Sometimes just mishandling or dropping of the device or just common wear and tear can lead to the device being inaccurate. It is important to note that depending on what blood pressure monitors you have in the office or in your hands, the calibration schedule varies. And what we're seeing with a lot of our partners is that this is a step that either is completely missed, or the calibration is not happening at the recommended time frame. That leads to inaccuracy in the blood pressure. I want to note here that automated blood pressure require a less frequent calibration. And if you're thinking right now whether the calibration is being done or not at your institution, please note that most of the time for healthcare system, the calibration is done by the biometric department. If you don't have one, usually a lot of clinics will partner or contract with a third party. So this is a moment where this is a step that can be very quickly addressed if the blood pressure devices are not calibrated. The next word, if we can move on to the next slide, that again supports accuracy in the blood pressure, it is using automated devices. Automated devices are allowed to reduce the human error that comes usually with a manual device. They also allow the clinician to focus on preparing the patient and positioning the patient. And as I mentioned earlier, automated devices require a much less frequent calibration, which again ensure that those measures are accurate. Talking about preparation and positioning, we'll move on to the second step, or the second action step, that ensures accuracy in blood pressure measurement. We're going to move on to the next slide, please. You're going to see an infographic that we have made available. This is an infographic that is publicly available, and this shows the proper position that a patient needs to be in for an accurate blood pressure reading. We have found that a lot of the collaborators and clinics that we're working with use this infographic and have placed this in the primary care offices, in the areas where vital signs are being taken. And we're learning that this serves not only as a reminder to the clinical teams about the accurate position, but also it helps the patient to recognize and position themselves. Next slide, please. When we talk about preparation and positions, a few things there are a lot of things that are important, but we've identified here a few that we keep hearing again and again from our collaborators and in clinical practice. Number one, making sure that patients are taking their blood pressure medications as scheduled. This is something that can be done either as we continue to communicate with our patients, whether you as a physician, whether a care team member, a pharmacist, a nurse care manager, emphasizing adherence to medication is important. But this is also something that can be done via an alert within your system. When you remind the patients about their appointment, maybe a reminder to take their blood pressure medication as scheduled can help, or the pre-visit planning when those are available. Additionally, encouraging or evaluating if empty bladder is needed from patients, but prior to checking the blood pressure is often something that is missed. So we encourage the care teams to focus on that. And then the last piece that is very important is ensuring that the patients are resting for 3 to 5 minutes. And making sure that this happens, that is when creating a protocol or a workflow about accurate blood pressure becomes very important. Next slide, please. Workflows. This means identifying who within your care team is going to check the blood pressure, when should the blood pressure be repeated, what devices should be used to initiate and to confirm blood pressure measurement, and then how to document those elevated blood pressure so that the prescribers can respond. And I want to talk a little bit more about who within your care team should check the blood pressure. Next slide, please. This is a graph that shows the alert response to the patient's systolic blood pressure where a nurse enters the room, which is the blue line, versus when a physician enters the room, which is the red line. As you can see, when the nurse and the physician enter the room, there is an alert response. You can see that the systolic blood pressure increases. However, over time, the blood pressure comes back to baseline when a nurse is part of the care, is the one who is checking the blood pressure, versus when the physician is, when the systolic blood pressure remains high. So what this means is that if we continue to support our nurses and our MAs, we support their training on blood pressure, their retraining, and empower them to take the lead in accurate measuring blood pressure, we are going to get blood pressure values that are more accurate. On the next slide, we're going to move on to the act rapidly, which as a pharmacist, this is the pillar that I am very passionate about. Act rapidly means providing timely and responsive, effective treatment for every patient with uncontrolled hypertension. It seems so easy. However, as Mike mentioned earlier, the evidence is showing that we are not treating patients appropriately. If you go to the next slide, we're sharing with you some data in terms of the medication use for patients who have a diagnosis of high blood pressure. And as you can see from this graph, about more than 30% of patients who have a diagnosis of blood pressure that is uncontrolled are on 0 medication. Another 27% are on 1 medication only. And when we know from all the clinical trials that most patients would require at least 2 or more medications to get them to goal. So what causes this lack of prescribing? It's really tied into therapeutic inertia. Can move on to the next slide, please. And this is where therapeutic inertia, again, it's simply the lack of treatment intensification when a patient's blood pressure is high. It is a complex issue because it is impacted by a lot of system factors, patient factors, and also provider factors. And when we dive in to understand the physician's factors that impact therapeutic inertia, we've identified a few that I want to discuss with you. Next slide, please. Number 1, lack of trust in the blood pressure measurement. So this is another key point that emphasizes how important it is to have an accurate blood pressure reading. The second element that we see, which is something that Mike alluded to already, it is we tend to overestimate the impact that medications have in lowering blood pressure. Additionally, physicians usually have concern about the cost of the medications or the medication adverse effects. And then there is still in the discussion that we have with different clinicians across the country, making sure that we have identified a patient's blood pressure goal. Our recent guidelines, which are not so recent anymore because they've been around for almost 7 years now, have made very clear that most patients will have a blood pressure goal less than 130/80 for better cardiovascular health outcomes. Next slide, please. As we continue to talk about therapeutic inertia and treatment intensification, we also wanted to bring to you some of the data that speaks to how important that is in controlling blood pressure for the populations that we serve. This is a modeling study that was done a couple of years ago by CDC and A Million Hearts, which tried to identify and compare medication adherence versus increased follow-up versus treatment intensification and their individual impact on improving blood pressure control. As you can see in the slides here, if we are able to get medication adherence to 100%, which seems impossible to do, we can definitely improve blood pressure control. However, it's going to improve from a 46% to a 57%, not an impressive population health control of the blood pressure. The same thing we see if we increase the frequency of follow-up, and if we create capacity to see our patients every week, we still will not be able to achieve a blood pressure control over 80%. However, if we change our prescribing habits, and if we're able to intensify therapy 3 out of 4 times when that intensification is needed, we should be able to achieve a blood pressure control over 80%. So from the population health perspective, it makes sense that we do focus and pay a lot of attention in treatment intensification for better blood pressure control. So how do we do that? How do we overcome therapeutic inertia? Well, if we move on to the next slide, we've identified 2 specific action steps. The first one is using combination therapy, ideally as a single pill combination when intensification is indicated. And the second step, it is using a medication treatment protocol. So using combination therapy, next slide, please. Mike had mentioned earlier that we know that most patients, again, will need more or 2 medication classes. And when you add a blood pressure medication to a current regimen, you have 3 times the blood pressure lowering effect comparing to increasing the dose of the existing medication, which we know and we see it's a common practice. So increasing the dose of medication and seeing patients every few months just delays the time for them to achieve control. Starting patients who have a blood pressure above 140/90 on a combination therapy, it is guideline-based therapy, and it provides a more effective treatment that it's patient-centered, especially when we recommend as a single pill combination. And then the second point here, again, is something that we already mentioned, is the fact that most patients will require 2 or more medication. So why delay the start of the second drug that it's necessary to achieve blood pressure control for most patients? And talking specifically about single pill combinations, again, that is patient-centered because it supports adherence. It allows us to give a more effective treatment that has better hypertension control, but also there is evidence that using a single pill combination is associated with better cardiovascular health by decreasing morbidity and mortality. The second step, it is use of a medication treatment protocol. Next slide, please. So what we mean when we talk about a protocol, it's really a one-pager that is easy to follow, that allows the physician at the point of care or the prescriber to make a quick decision. Number 1, to know exactly what would be the next step in therapy. And number 2, the protocols who have an example of medication list allows that prescriber to identify the exact medication that they could or should prescribe for their patients. The protocol serves as a playbook for the whole care team, which supports that messaging that we all should provide to our patients, the same message about their goal, about their treatment, and about the follow-up. Whether you have a medication treatment protocol in your institutions or whether you're thinking about creating one, there are a few steps to keep in mind. Next slide, please. Number 1, everyone who's going to use the protocol, which is usually the physicians, other providers, clinical pharmacy, nursing team who works under a treatment protocol, can really benefit, and it's important that they have input in creation of the protocol. Number 2, placement of the protocol somewhere where it's accessible. If any clinician will have to click 5 or 6 times to get to the protocol, that protocol, it's not going to be effective. Number 3, provide education and support on the adaptation of the protocol. And number 4, it is important to have a system in place that will support the updates that may be needed to be done to the protocol, either because the guidelines are changing or because medication accessibility and cost changes. And again, whether if you have a treatment protocol, take a look at it and see if updates can be made to make it more effective and efficient. And if you don't have one, collaborating with your pharmacy resource at your institution, whether it's the Department of Pharmacy, clinical pharmacy service, can really expedite development of a medication treatment protocol. Next slide, please. We're going to focus now on the third pillar of our framework, which is partnering with patients. There are 5 action steps that we've identified to be very successful in allowing patients to engage in their care and to support medication prescribing and accuracy in the diagnosis and really in staging of the high blood pressure. These steps are: number 1, follow up frequently. Number 2, using collaborative communications with patients. Number 3, assessing and addressing medication adherence issues. Counseling and provide support for lifestyle modifications, and using self-measured blood pressure, and specifically building self-measured blood pressure programs that can drive success. I'm going to focus just on a few of these points. The next slide, please. When we talk about following up, the recommendation for any patients who has started on a new medication or where medication intensification is completed, we recommend a follow-up every 2 to 4 weeks until blood pressure control is achieved. The follow-up does not have to be done in person. It can be done virtually via telehealth. It doesn't have to be completed by a physician or a prescriber. Pharmacy services, nurse care managers, nurse visits. In some institutions, community health workers are connecting with patients to get those home blood pressure readings. Those are all follow-ups that help patients stay engaged and gives them the message that we care. And then really utilizing the self-measured blood pressure results to drive that treatment intensification. The next slide, we're going to talk a little bit about supporting medication adherence. We know that when it comes to medication adherence, it's poor for hypertension control. Only about 50% of our patients take their medications as prescribed. And while this is a very complex issue and we can talk about it in a whole webinar, I wanted to highlight a few system-level interventions that can help to drive medication adherence. Number 1, it's for those patients who are on the right therapy that has achieved control, making sure that they do have access to their medication via prescribing 90-day supply with 3 or 4 refills, depending on the laws of the prescription lifetime in your state. Number 2, incorporate medication reconciliation into the workflow. Meaningful medication reconciliation can make a significant improvement in medication adherence. Number 3, develop standing order for refills that require labs. If you want your patients to come in because you want to check a renal function, make sure that that standing order is in place and the lab is in place so patients can follow up and continue to take their medications as prescribed. And then addressing any barriers to transportation, not only for the patients to connect with the health system and to come in for a doctor's visit, but also for access to their pharmacy and their medications. Next slide, we're going to talk a little bit more specific about steps that an individual clinician could take to support medication adherence. Number 1 is shared decision-making and collaborative communications with the patients. There is so much information online that patients can access on their own. Correcting misinformation, it is essential to make sure that patients understand the benefit of their treatment, the risks that are associated with it, and how do we monitor so that we can achieve success. Prescribe single pill combination when possible. We continue to emphasize this because it's been shown to be a key in improving medication adherence for blood pressure control. And then collaborate with pharmacy services that can support medication access, but more importantly, medication monitoring. The last action step that supports partner with patient. It is the use of the SMBP, self-measured blood pressure, and building a self-measured blood pressure program. Next slide, please. We have developed a lot of resources around self-measured blood pressure and how to make this program a success. And I'm sure that many of you are probably familiar with some of those programs that may be built into your institution. However, there are specific steps that drive and make this program successful. We can move on to the next slide, please. I've listed here 6. There may be more steps here, but again, some of them are a repeat of what we've just learned from our work in clinics and with other partners. Using validated upper arm devices is important. Obviously, making sure that patients are educated and preparation and positioning, having a way to relay the result back to the clinical team and creating a strategy to respond to those results, it's key to drive the success. What I want to spend a little time on, though, it's really educating the patients on how frequently to check the blood pressure at home. Often what we're seeing is patients either are given a device from the doctor's office, or an order is being sent for them and they're told to check the blood pressure at home and report back maybe in a week or 2. But the most recommendations do not become more specific like that. And we're learning that lack of that specificity makes it harder for the clinicians to get results that are meaningful and actionable. So I want to spend with you a minute to clarify some of the recommendations that may make it easier for patients and for clinicians. Usually, we need about the data is telling us that about 12 blood pressure readings in a 7-day period, when they're measured accurately, could be representative of a patient's blood pressure at home. So if you are going to follow up with a patient in 2 weeks or in 4 weeks, you can ask them on the last week before they're going to follow up. Pick 3 days out of the week to check your blood pressure. Check the blood pressure in the morning and evening. And every time you check, get 2 readings a minute apart. That will give us a total of 12 readings. And when they're averaged, we'll have an accurate and representative blood pressure that can not only can help patients stay engaged, but can really drive that treatment intensification. Next slide, please. So what I've summarized with you, it's really the 3 pillars and the action steps within each pillar then help us to support blood pressure diagnosis and staging of the hypertension, helps overcome therapeutic inertia, and supports adherence to treatment and engagement with patients. And when these pieces work all together, that's how we can achieve blood pressure control. And with that, I will pass it on to Shannon.
Hi, next slide. Thank you. I'm Shannon Haffey. I'm the Director for Ecosystem Strategies and Community Impact, and I will talk a bit about how we can help bring our MAP framework and program to your organization. Next slide. Oh no, that slide, sorry. As Claudiana described, we work with healthcare delivery organizations to improve blood pressure control through these 3 strategies. The M, the A, and the P components are typically implemented over a 6-month period, and we work to customize the program for your infrastructure and your organizational needs. Each component is based on evidence-based actions, and we have tools and resources to help. We also offer quality improvement coaching, which can be in-person and virtual, in order to drive improvement in blood pressure. One critical component is data and analysis. It's an essential part of our program so that we can provide metrics to the clinical and quality teams, but also track progress towards goals and identify opportunities for improvement. Next slide. Our collaboration approach is to work with you from the beginning. Our team works with your team to implement the MAP QI program. And our team includes, as you heard, not only physicians and pharmacists, but also other clinicians, nurses, information technology specialists, and measurement experts. We support the planning process on how to implement the program, as well as through launching the program. And then we have ongoing support even after we reach goals in order to sustain progress that's made in blood pressure improvement. Next slide. The benefits of our program include helping healthcare organizations to improve health outcomes fundamentally and improve patient population health, We also focus on how we can improve efficiency with team-based care approaches, like Claudiana highlighted, the difference in taking blood pressure when a nurse is present versus when a physician is present. We look to enable leveraging actionable data where we are using process metrics as well as outcome metrics so that we can identify opportunities earlier in a patient's journey than just at the outcome, which also aligns to many of the financial programs and reimbursement models that many of you participate in, which is we want to look at data earlier than in the year than just the outcomes data at the end of the year. This program is available at no cost to your organization. We in Improving Health Outcomes are part of the mission work of the AMA, and this is our investment back into clinical practices. Next slide. You can contact us for more information either using the QR code or the email, and this will be provided after this session as well. While everyone maybe takes a minute to capture the QR code or email, we also work with organizations like electronic health record organizations, payers, population health vendors. It's part of our ecosystem work to enable improved blood pressure control for the types of systems and processes that you all support. This includes things like embedding metrics into EHRs for your clients, or we can host dashboards that your clients can use leveraging your data and process. With payers and population health vendors, we're also looking to enable these MAP strategies, tactics, and metrics. And we have some other solutions that are relevant, such as ensuring that validated devices are always used in office and out of office for self-measured blood pressure, as Claudiana described. Next slide. Sharing a snapshot of our published results. When we started our journey over 10 years ago, we developed our framework in an academic setting. And then we really wanted to bring this framework to healthcare organizations of all sizes and structures in order to improve blood pressure control. We moved to implement within busy practices and primary care, to working with FQHCs around the nation, and also those organizations who have been serving populations that have been historically marginalized. So this is a sample of some of our published outcomes and peer-reviewed results, and we're happy to talk about more use cases and studies as well. And with that, I'll transition to my colleague, Allison Welton, and we'll do some Q&A.
Great. Thanks, Shannon. And thank you to those of you who have put some questions in the Q&A section. We'll move on to the first question. It's to Dr. Miftari. Most clinicians are hesitant to start patients on combination therapies. This is often due to concerns about side effects and cost. Would you be able to speak to some of those concerns?
Yes, absolutely. Thank you so much. You're absolutely right. Most clinicians are concerned about side effects. We'll start there because safety is first. However, what the data is showing us that when you use combination therapy, especially, you have the potential to start patients in a lower dose, which means that if you have two medications that are at a lower dose, what we're seeing is the side effect profile could be better than starting patients in a standard dose or a higher dose. Additionally, there is evidence that says when comparing using combination therapy versus using single medications, the discontinuation of medication rate is not higher. So some of those fears that we have, we have an opportunity to manage side effects because of the knowledge that we have around the medications. But also, if we start patients with a lower dose, we could prevent some of those side effects. When it comes to cost, we are fortunate that there are many medication classes that support blood pressure control. Many of them are available in single combination pills, and they are covered. They are available in generics plans, whether it is Medicare plans or private insurance or even Medicaid plans. They all include single pill combinations in their formulary as tier 1, which means that the copays for these medications are relatively low. So again, to address your question, those concerns are valid. However, there is evidence to support that using combination therapy is safe, it's effective, and it is then the cost, it's not necessarily a barrier, more so than a perceived barrier that can be minimized by knowing exactly what medication is available to your patients through building a medication treatment protocol. I hope that answers the question.
Great, thank you. Next question is to Dr. Ray Cox. We seem to have success getting nurses to take a confirmatory BP reading, but cannot get the physicians to use a treatment protocol to standardize prescribing practices in our organization. Any suggestions how we can address that?
Well, I think it goes back to some of the things that Claudiana said earlier. You know, when it comes to adoption of an evidence-based treatment protocol within an organization, the process in creating that protocol being inclusive, including primary care physicians, you know, a multidisciplinary team, preferably including pharmacy and nursing, that all helps create an excellent protocol. There are many available that a lot of the health systems and health centers that we work with use already. But you've got to get buy-in from the physicians for sure if they're going to use them. So, you know, having more inclusivity on the team representing, in particular, primary care, who manages most hypertension, is going to be critical. And then, as Claudiana also mentioned, you've got to have some system in place to assess whether or not they're being used. You know, I think the real challenge here is that we've talked to thousands, literally thousands of physicians about this and many other issues, and most people prescribe what they were trained to prescribe when they learned how to diagnose and treat hypertension. For many physicians, that was decades ago. And while some things haven't changed, many things have changed. People get into the habits, and most medications do work. But often the recommendations change to not recommend a drug class now that was recommended, say, 10 or even 20 years ago. That's a huge factor, and it can be a barrier because the reason those medications are no longer recommended first line is they're thought to not work as well. Similarly, to Claudiana's comments earlier, you know, the importance of initiating with single pill combination therapy, with combinations of medications in a single pill, you know, there's a huge benefit to that, while there may be concerns from patients that they're going to get too much medication, discontinuations have not been shown to happen at the rate that many patients think. And I think more importantly, many physicians overestimate the number of side effects that happen. So while we thought for many years that the reason that medications were being suboptimally prescribed was patient resistance, while that's a factor, we know that there's a lot of physician and prescriber resistance to prescribing more medication that is not necessarily supported in the literature. When you look at studies, they tend to show that by using single pill combination therapy initially, instead of a monotherapeutic agent, you'll get more people to goal, you'll get more people to goal more quickly, and most importantly, those people will have better outcomes, even up to a 20% reduction in all-cause mortality compared to those started on monotherapy. I think that's an often missed point that's extremely important. Patients do better from an outcome standpoint and a treatment target standpoint when therapy is initiated with single pill combination therapy instead of monotherapy. And to illustrate this, I think this is a lot of evidence has come out in the last 10 years to support this. And I think this is why the European guidelines, which was updated more recently than the current US guideline, now recommends that most people with hypertension be started on single pill combination therapy, unless there's a compelling indication not to. Whereas in the United States, I think we start most patients on monotherapy and look for a compelling indication to go to single pill combination therapy, like a 20 millimeter systolic distance from target, things like that. So there's sort of been a paradigm shift in many parts of the world. I think we're a little late in the United States in getting to that. Hopefully with the next guideline that is due out next year, we'll see an update there and an even stronger recommendation to initiate with combination therapy. So hopefully it'll make things easier. The goal in Europe is that if most patients are started on a single pill combination of 2 medications, if you need to intensify, you can go to a single pill combination with 3 medications. They believe that that recommendation alone will get the continent of Europe to their desired blood pressure goal of 80% control from currently less than 50. Just by having that one recommendation in a treatment protocol. So it's a long answer to your question about how do we get people to use treatment protocols. I think we need, a lot of education and understanding, translating scientific statements and guidelines into clinical practice with very plain language about why that's important, how it's better for patients, how it improves patient outcomes, less heart attacks, strokes, and premature death. I think that's really, really important, along with some key processes to make sure that you can track whether or not those protocols are being used, and if they're not, find out why.
Great, thank you for that. Final question to Shannon. What are some of the most common barriers faced by a healthcare organization when they implement your program into their already busy primary care practices?
Yep, thank you for that. The first is really identifying the right team who is dedicated towards implementation and quality improvement. And one of the things that we work on with implementation is really looking at who within the team has a role and can participate. And so, as Claudiana explained, each of the 3 strategies, different roles are involved. So there's often clinical sponsorship from the beginning. And then as we move into implementation, different roles surface as having a key role, such as the clinicians taking blood pressure, to also information and technology roles to enable the clinical data and the reporting that we can act upon. But it's something that we work on is clinical care team time, so that this is not an added burden, and that this program can be prioritized as an evidence-based program as quality improvement teams look at opportunities and priorities for the year. Other barriers that come up are actually within healthcare organizations, but may not be the clinical care teams charged to solve. And those are things like, how do we look at alignment to reimbursement and what payer contracts might look like? And that is also something that we are building experience in, especially as most recently, the last couple of years, self-measured blood pressure is now a reimbursable service, as well as we look to ensure that the provision of validated devices, both the education on how to use a device for a patient and also taking in the data. So when the care team is taking the data back from the patient and making treatment decisions, that is now reimbursable. And so we look at things like that to make sure that this can be a financial priority as well for organizations. And we're looking at alignment to quality measures and federal payment programs and things like that. So not necessarily barriers, but definitely help to prioritize clinical quality improvement when there are aligned financial incentives as well. Mike and Claudiana, would you add anything?
I think that's excellent, Shannon.
Great. Well, thank you to the 3 of you for your answers, and many thanks to those of you who submitted the questions. Now I'm going to turn it over to Mike Smith to close us out with final thoughts.
Yeah, fantastic. Thanks, everyone. And thank you, certainly, Dr. Raykotz and Muftari and Shannon, for the work that you guys are doing to help mitigate hypertension. And certainly we would encourage all of you to seriously explore leveraging the MAP framework and quality improvement solutions to reduce hypertension within your patient populations. Also, for insights on some of the technologies that are being used to manage some of these chronic conditions that we talked about, or to enhance your clinician's experience with their EHR, please don't hesitate to contact KLAS Research. You can see we've got some contact info here on the final slide, and certainly feel free to use that. I know that we'll be sending out this PowerPoint to all of those who attended, and we do have a recording available as well. So thank you for attending, and have a fantastic rest of the day.